Okay, so I thank you all for joining again for this, our fourth and last week of this series on Jewish medical ethics. And the case for the week is kind of a derivative of a few different ones, but also real. An older man seeks evaluation for shortness of breath. The chest X-ray shows a large right-sided pleural effusion. That's fluid between the lung and the chest wall. He's treated with a chest tube in order to drain the fluid, and his symptoms of shortness of breath go away. The material from the fluid is sent to pathology, to a specific area of pathology called cytology, and they identify malignant cells, likely of lung origin. There's sufficient material that they are able to analyze for surface markers for one of the novel agents, such as the immunotherapeutics that you see advertised all the time on what I like to call old timers TV. I watch old timers TV all the time myself. Unfortunately, there are no markers that would indicate that a targeted therapy or an immunotherapy would be beneficial. The only thing that one could do would give chemotherapy. The family requests that the patient who does not speak English not be told the diagnosis, since in their culture, discussion about life-threatening illness or cancer is done with the family, a surrogate again, and not with the patient who would be severely distraught by the diagnosis. Now, we will not answer this ethical dilemma just yet, but I will frame it for you that the ethical dilemma is that the way that the family puts it together, sanctity of life might be violated, the patient so severely distraught that he would die or commit suicide or whatever, and patient autonomy is subordinated to that sanctity of life clause. And there's also another one that we're going to talk about, and that is non-maleficence. So that's what the issue is at hand here. Now let's see if I can make this advance. Please tell me. Are you able to see me advance to the next slide? Okay. Yes. We have talked around these moral rules quite a few times over the last few weeks. And I've always been telling you that these are what are called secondary deontological principles. They're not primary because they're not universal. They're not accepted by all cultures and not expected to be intrinsic into the rights of human beings in every place, but they are aspirational in some cultures. Veracity, that is telling the truth. Fidelity, which means being faithful to the relationship between the practitioner and the patient. Confidentiality, I think you all know what that means. And privacy, very similar, but not exactly the same ethical principle. But these are considered, even in our culture, secondary because we violate them and we make them subordinate to the primary principles. Again, I use an example that if I hear about somebody in session who has an obsession with another person that he would like to kill, for example, or commit bodily injury, or perhaps even something less severe like rob, I may be required by the state to turn in that person and violate the confidentiality that was assumed in the course of our discussion, because the confidentiality rule is subordinate to other rules like sanctity of life. Now, there's another major principle that we didn't talk about. We talked about sanctity of life. We talked about autonomy. There are two others that we didn't talk about that are primary. And this is called the principle of non-maleficence. We teach it all the time to medical students. We use a Latin expression, primum non nocere, first do no harm. And it is basically the principle of not doing harm to others. This is a recognized duty, regardless of what theory you're practicing under, deontological or utilitarian. And it is distinct from beneficence. Beneficence is doing that which you believe to be good for another person. It's enshrined in the Good Samaritan law. But it is not enshrined elsewhere in medical ethics and not so much in jurisprudence either, because there's a lot of difference of opinion about what is beneficent, what is good. The Catholic Church, since the Middle Ages, has focused a lot on doing that which is good as a major ethical principle. But in medicine, we have some trouble with it because what is good in your mind might not be good in my mind, and it could violate a lot of autonomy principle. So we actually prefer to say we will not do that which is bad, because there's a little more agreement on what is bad than what is good. This is an action rather than an attitude. Now, it is difficult to define sometimes what is harm. Certainly negligence is harm. If one ignores a person who needs medical help, you can be charged. So maybe there is a little bit of room for beneficence, but on the other hand, for the most part, we would actually prefer not to harm a person. We use non-maleficence all the time in justifying a certain withdrawal of care at the end of life, because we say that even sometimes putting in an IV, certainly sometimes bigger things like doing an operation or draining fluid from the chest is not something without potential risk of inducing harm and hastening death. And so we have trouble justifying interventions at the end of life because they cannot be construed as non-maleficent. There's one more principle. So we've done 3 and there's one more, 4, justice. And I've talked a little bit about justice too. It's hard to define. I guess the simplest definition is fairness, giving to each his or her right or legitimate claim. But there are many different kinds of justice out there, distributive, comparative, non-comparative. Mostly what we're talking about in medicine is distributive justice. How, if you have a limited resource like medical care, do you distribute that resource fairly without some sort of hierarchy of who deserves care? So that becomes a major ethical principle in medicine. In Judaism, I think all 3 types of justice are discussed. You know, the famous biblical line, tzedek tzedek tirdof, justice, justice shalt thou pursue. And many biblical authorities view the use of the word justice twice, tzedek tzedek, justice, justice shalt thou pursue, to mean almost like celestial justice, justice on a heavenly scale that encompasses all of these different competing claims. Now, medicine typically involves, as I said, distributive justice, the allocation of limited resources, the concept of scarcity. And our major principles are that we need to distribute this equally based on need, less so based on effort, and probably least based on societal contribution. But as you know, there are societies that have constructed themselves based on contribution rather than need or equality. And there's some examples in biblical texts and Talmudic texts and so on. If 2 people are traveling on a journey in a desert and one has a pitcher of water, the Talmudic author Ben Batura said that it is better that both should drink and die, even though drink and die, even if there's insufficient water for both. Rabbi Akiva, however, said that the verse that thy brother may live with thee means that your life takes precedence if you are the one who possesses the water. As you can imagine, there's a lot of discussion over this. The next line we've talked about before. A man takes precedence over a woman in matters concerning the saving of a life. A priest takes precedence over a Levite over an Israelite. But if the bastard is a Torah scholar and the high priest is unlearned, the scholarly bastard takes precedence over the ignorant high priest. So this means that even the construct of justice is subject to much discussion and qualitative assessment. There is a definition of rights. Now, rights are claims, but they are not necessarily duties. So we've talked about your right in the state of California to ask for a lethal injection when you're dying could constitute an obligation for me. And so your rights do not trump my rights to say no. You cannot put on me an obligation. Even if you have a right, you'll have to find somebody who's willing to do it. And so there are differences. Duties are different from obligations. Duties obviously follow some ethical principle, and obligations a little less so. Now, I'm not going to talk about fertility because that gets us off the topic, but I will talk a little bit about suicide because I just mentioned it. There are a lot of ethical principles that come up in suicide. The one that allows a person to commit suicide or ask for a lethal injection is autonomy, obviously. However, it does violate sanctity of life. There's very little way that you could construe a lethal dose of medication as non-maleficent. You might call it beneficent, but you could never say it's non-maleficent. And the question is it justly distributed to all? Is there a principle of utility at hand? Now, there have been a lot of human experimentation projects. We talked about some of them last week, and all of them have problems with non-maleficence, because not one of them can be construed in any way as not non-maleficent. Not one of them can be construed as giving autonomy to the patient, because these studies were not done with patient consent. And many of them, of course, violate sanctity of life as well. Just to go through a few of these, the Willowbrook State School Project, that was a place on Staten Island in New York where mentally retarded kids were housed. Developing hepatitis was very common there. And there was a physician group that tried to do a study to determine how hepatitis was, how people developed hepatitis and how hepatitis progressed. And so rather than doing anything that might have protected individuals from the spread of hepatitis, not that much was known at the time in the 50s and 60s, people who were housed there were purposely exposed to individuals who had hepatitis, the justification being that they had a 90% likelihood of getting hepatitis at some time during their stay at this institution anyway. They might as well do it under the close watchful eye of the doctors to see what would happen. So what is that? Of course, that's a violation of autonomy. That's a violation of sanctity of life. It's a major violation of non-maleficence. The UCLA Schizophrenia Project was a little trickier. I don't know how many of you remember this. It had a lot of visibility in the press. In the UCLA Schizophrenia Project, patients who had been stable for a long period of time were given the opportunity to go off their antipsychotic drugs. Surrogates actually also signed informed consent, but the informed consent did not describe all the potential things that might happen. And it came out that when some of these patients started showing early clinical features of relapsing psychosis, there was no intervention to start them back on medication. And one of the subjects committed suicide. So this was quite a major violation. It was not totally a violation of autonomy because patients or their surrogates could give consent, but the consenting process didn't describe some of the potential things that might occur if patients started showing evidence of recurrent psychosis. I think you know the Tuskegee syphilis study, which is brought up a lot in Tuskegee, Alabama, where individuals who had syphilis were allowed to progress through their disease to get an idea as to how untreated syphilis progressed. And this was done in an era when antibiotics existed that would have arrested syphilis. So this certainly was not, was a violation of non-maleficence. It was a potential violation of sanctity of life. And we, to our knowledge, there was no autonomy involved in terms of informed consent. And the same with the US Armed Forces Chemical Defense Research Program, which took place on individuals exposed to various chemicals that the Navy was using, as well as other divisions of the armed forces in Asia. So that, I think, is kind of our background overview. And let's take a look at a little bit of guidance from the text before we decide what we do with the patient that I described at the beginning, okay? From the texts, we learn that everything may be utilized for healing because of sanctity of life, save for idolatry, some forms of sexual licentiousness, and homicide, the three big things that you even must give up your life in order to avoid going down that pathway. Rambam said that that which the Torah does not permit to be used for healing cannot be used. Leviticus, older, of course, Torah text, you shall not walk in their statutes. In other words, don't copy what other people are doing when it's outside the nature of your religion and your culture. And I think the most interesting one, especially vis-a-vis organ transplant, is this one from Talmud: the stone with which the condemned was stoned, the stake on which he was hanged, the sword with which he was beheaded, are all to be buried with him. It is a violation, a sur, the hana'ah. It's a violation to profit from basically the dead. And you can see how that had to be dealt with when the concept of organ transplant developed. So here's a bibliography for you to look at, but I'm going to scroll back quickly. Don't get dizzy, to look at our patient history and ask this time the assembled audience here to tell us. I'll actually assign you, maybe, because there are not so many of us. I'm going to assign Claudia to say the answer is no. You will tell the patient his diagnosis. So give me justification why you could say no, you're not going to do what the family wants.
Well, it's Claudia and Eddie.
Okay, and Eddie.
Well, I think the patient should have agency over treatment that will be offered to him, and I believe that every patient should be told the truth.
So here, for you, autonomy is like the ruling principle.
It is ruling principle. I have to say, this was the ruling principle for me up until a couple of weeks ago when I happened to watch a movie. I forget the title, but it's set in China. You might have seen it. And the family who lives in the United States goes to visit their grandmother who's been diagnosed with lung cancer. And they don't want to tell her because the culture is not to tell the patient, and the family will discuss it. And they made a case, which is very compelling, for not telling them, for not telling the patient. And I had to reevaluate my my belief. Although as a patient,
you still came down on the autonomy side.
But I still came down on the autonomy. Oh yes, absolutely.
Can I add something to it?
Please.
You know, it seems to me that you have a definition of the relationship between the doctor and the patient that changes from culture to culture, probably geographical location to geographical location. In the United States, I believe the relationship is between the doctor and the patient. And it's a very simple, solution to the problem. If you want to be treating cultures where it's not necessarily appropriate to consult directly to the patient, and get a waiver directly from the patient to say, hey, you have my permission to talk to my family instead of me. That's how we do things in our culture. But they have to sign it, because otherwise, if they don't sign it, you don't know if the family is just trying to do, maybe nefarious things or not. There's no getting around it. It just, if that's the way it is, what's the harm in acknowledging it? And everybody saying so above board before the treatment begins.
Okay, that's a good workaround. Now, let's ask Marshall to not opine. I want you to represent the side where you say, yes, I will do what the family wants.
Well, I'm bothered by the lack of informed consent here, because the doctor has no way of knowing whether informed knowledge is being communicated to the patient, because there's a barrier between the physician and the different culture patient. But if you want me to take the position of the family should control, I would say whether it's a proper advance directive or not under California law, one could argue that the family occupies the position as the patient's agent, and the information given to the agent is imputed to the patient. And on that basis, I would argue that the family in that culture is acting as the agent, and therefore the answer could be yes. That's the argument I would make.
Okay, but you just basically said what Claudia said. I mean, in a way, you came up with a different answer, but both of you again worship at the altar of autonomy. I want somebody to use a different ethical principle. Here, the family, Marshall, you basically say, is in a way the surrogate for the autonomous wish of the patient. Okay. Can you take a position not using that ethical principle? Oh, yes, you can. Ken, you can do this. I know you can.
Well, before we get to that, I want to point out, is the patient coherent enough to discuss it himself?
Yes, but, okay, I tell you what, let me make it a little harder, more realistic. Can't speak English.
Well, that happens all the time at the hospital.
Right.
I've been there
all the time. This is Los Angeles. That's the norm.
And they have interpreters on call, whether it's in person or on the phone. And the first thing I would want to know from the patient is, do you want to know, regardless of what your family says?
Is that a leading question?
No, I think it's a right of any patient to know if they want, or I want to say, no, I don't want to know. Tell my family, but don't tell me.
Okay.
That's as far as I can go.
Okay, we have a couple of others on the line. So let's see if one of them, Rodney, I see you here. I don't know.
No, I totally agree that the patient has to be given the opportunity to know, and if he declines, that is his right. He can designate someone else to be told, or no one to be told, but on the basis of autonomy, the patient has the right to determine whether or not he should learn what his diagnosis is.
Okay, I appreciate all of those. I'll tell you maybe what my position would be, although since this is not completely a real case, I don't know if I would do what I'm going to say, but I think I would. I would say that, and I've done this before, it's sort of a workaround. I would say, if the patient asks me, what is the diagnosis? What is the cause of the fluid in the chest? Then I will say what the truth is. And if the patient does not ask me, I will assume that the patient does not want to know. That is an assumption, of course, because I do respect the concept that my diagnosis might shorten the patient's life. Just telling the patient that he, or in this case it is a he has cancer may shorten his life. Now, where it becomes sticky is if I do need to do any procedures. Because you're right, we are functioning in California. We are functioning in a state where autonomy is very important. So any procedure that's more than a simple blood draw, I think we will probably need to go down this pathway, because it'll be very hard to get consent if we need to do surgery, or if we need to keep the chest tube in or replace the chest tube or whatever. I think we're going to get into a sticky place.
What if the patient was not competent?
That's easy because their autonomy is always subordinated to the surrogate. Now, we sort of went down that path before. Now, if there's disagreement among the surrogates, should the patient get chemotherapy? Should the patient not get chemotherapy?
How does the doctor know? How does the doctor know who the designated surrogate may be?
Well, if there's a durable power of attorney for healthcare, you're in a good shape. If there isn't, this takes us, you're bringing us full circle around to week one. If not, then we actually try to make peace. We do these things called family meetings. I hope you never have to go to one, where all interested parties are brought together with the practitioners, and that's usually in plural. So they're physicians and they're nurses, and there might be consultants and so on. And a lot of the discussion is actually centered on differences of opinion regarding facts, like we talked about. Is this remediable? What will the side effects be of the therapy? What could you possibly achieve if you did X, Y, or Z? And what we don't get to is, again, some of these bigger issues, like to what extent would you go? What is your goal with this? And what would the patient want? If there's disagreement, we try to be Solomonic. Yeah, go ahead. Sorry, I interrupted you.
Can I take this out of the theoretical into the real world?
Sure. This is close to real, but not to.
I'll go. No, but this is the real. I'll get you right to the heart of the matter.
Okay,
so my mother has fought 3 different cancers: lung, breast, and ovarian. The last was the ovarian cancer. She just completed, and she's 83 years old with moderate, to very moderate dementia. Mm-hmm. Her executive function is fine, but her memory is disappearing. And that makes you really completely unsure of yourself.
Right. She
just got the radiology back and found 3 things in the radiology after the completion of her chemotherapy. One is on the left side of her lung. She had a prior nodule that has grown by from 8 millimeters at its longest dimension to 12, which you realize is a 50% increase. And in addition, there's a new nodule right next to it that wasn't there from the prior CT. Second, the lymph nodes, I can't remember, the lymph nodes around the ovary where the prior tumor was removed are now enlarged. And there's the appearance of either significant scarring or some sort of invasion in the lower spine area.
Okay, so she has.
Let me finish. So we have all of these funny looking things in a CT that just came out after the completion of chemotherapy for her 3rd shot at cancer, and we had the family meeting. Now, the way that the doctor presented it to my mother really is not really doing very well at grasping these things. Is, well, there's these funny things, and there's a little bit of this over here, and a little bit of this over there, and this other thing over there. And so we'll keep an eye on things. And we'll probably do another CT scan in 3 months. And my sister and I, we don't say a word during this. So here we have the actual example of, do you tell the patient? What do you tell the patient? And what my sister and I decided was, and we showed the CT scan to a few other people, and it doesn't look great, but what are you going to do? But so the way we took it was, look, we're not going to. We played it just the way you actually described it in your example, where if the patient doesn't ask, I'm not going to say anything. And we knew that my mother was not going to. She didn't read it directly herself. We knew that she was not going to be smart enough to ask. And we didn't help her along with it. Now, maybe we'll get lucky, but the point is this: the way that the meeting ended was, and we'll do another CT scan in 3 or 4 months, and we'll do a PET scan at the same time. By the way, You understand what I mean? So you see where that's going. So here's the now what
you want me to
deconstruct
that?
I'll throw this over to you now. So
you want me to deconstruct it a little bit?
Yeah, go right ahead.
I'll try, and I'll try to put it in an ethical framework, and I'll try to finally put it in a Jewish ethical framework.
Yeah.
Because I do think it's pertinent here.
Yeah.
The first thing is the doc. What's going on perhaps with the doctor is that he just doesn't want to. He or she may not want to even get into it. So we do that too. You know, we have it's not justification. We have a lot of things to do. We don't want to be in this intense conversation. We don't want to deal with this intense situation. We want to get out of the room. So sometimes you can see that body language because you see the doctor talk and then begin to back out the room before the end of the discussion. That's not, of course, good, but I do know where it comes from. There could be an element of non-maleficence, because anything that the doctor will do to address what is likely progressive disease, you know, he should measure a CA 125, there are tumor markers, you don't need to do another biopsy. Anything that he or she is going to do is going to be harmful. The only way that you could justify something that's harmful, that is not non-maleficent, it's going to somehow prolong her sanctity of life. And the problem from the Jewish perspective is that there will be some point at which she will be in the active process of dying, and then it would actually be forbidden to harm her with the idea of sanctity of life, because you wouldn't sustain life. That's not true at this point. But certainly there's a non-maleficent issue. There is also, by the way, a little bit of a justice issue, because PET CTs are expensive and they're not equally accessible all over our healthcare system. You have a lot of trouble getting a PET CT from at the VA or at the county, not to mention repeated ones that you do over and over and over again. And so it's kind of hard to justify doing it on this patient when you know what it is anyway. And if you saw on a CT scan in 3 months that the tumors had doubled in size and number, well, you don't need a PET to be wasting that money and wasting that resource, which is not limitless. Okay, but again, in some environments, it is much less constrained, and it kind of avoids dealing with some of these substantive issues. And autonomy may not even come into the issue. It may not even come up, because we could have a good ethical discussion without even bringing in her right to agency, her right to make an informed decision. She may not be fully competent to make a decision. I wish she would be, because it would make it a little bit easier, but you could argue not doing something from non-maleficence and from the fact that it will not save her life.
But don't you reach the point where you'd be better off encouraging her towards palliative care?
Yeah, that comes up all the time. That came up today. You just happened to mention it. And much more difficult, I think. Well, we have ageism in this culture, so I think it's more difficult. But here, I'll tell you what happened today. I got a 39-year-old lady. She has a type of leukemia. We had to interrupt her original therapy because she got COVID in January. Her disease came roaring back, and we started her back on therapy, and we have never been able to get a sustained remission ever since. I even gave her an investigational protocol with cell therapy, engineered cells, and I just can't fix this. This thing is out of control. She's had every therapy licensed and investigational. She now has severe pain, is on narcotics, developed this morning, severe abdominal pain. And we actually wanted her to get hospice care. She wanted to be at home, so we were working on home hospice. But neither she nor the family want to do hospice because they don't want to give up. The husband told me in Spanish, and I'm Ken will tell you I'm pretty fluent in Spanish. I can conduct myself like I do here. And he said, God has, la última palabra. He has the ultimate word. And so God will decide what happens to her. So here it actually might have been beneficent to put her on hospice, but the surrogate and the patient, because she's still awake, say, no, we don't want hospice. So we have to guide them. We don't want to do something maleficent. I don't have any more chemo that would work anyway, but everything that I would do would be really bad. But I have to respect that she doesn't want to go on hospice and find some way to treat her pain, again, from a Catholic perspective, beneficent, without taking her life. It's going to be a tricky row to hoe. So it doesn't always go toward the withdrawal of care. Many times it goes the other direction, or there's a conflict because the medical care system wants to withdraw care. People are frustrated, they have too many patients, they don't think it's right from whatever their ethical heritage is, but the patient does want to do everything. And so there are some institutions, I don't know if they still do this at Cedars, but they had talked about doing it there, where if you got a committee together of ethicists and doctors, you could actually take away the person's right to supportive care if it was felt that the person was dying. Now, this has not been tested in court. I don't know where it would go. I hope one never goes to that, or that you never need to go into such a position. I haven't in 30 years. I haven't had to do that.
But you said supportive care. You didn't say therapeutic care.
Well, it's a euphemism. Therapy need not be with the intent to cure. Therapy,
True.
you can have different goals, right?
Well, I've actually seen it this week. I work at a hospital, and we have a patient who there's nothing more to be done for him, but the wife insists that treatment carries on. And eventually the doctors had to appeal to the board because they feel that the more interventions is going actually to hasten death.
Right.
So I've never seen that before, and I don't know how it's going to be decided or how,
Well, you have to, but I mean, the way you said it is a good way to say it, that, the treatment that one might use, for example, would hasten patients' demise, and it's not justified. So maybe you need to find some other therapy that wouldn't necessarily hasten their demise, but would still satisfy the spouse that something is being done.
Yeah, it's tricky. She wants, deep intervention. But anyway.
No, I mean, we see these things. It is very tricky. It's frustrating, and all parties come with emotional baggage when they come to the bedside. But as you learn here, what's so interesting, and I really encourage you to look at some of these bibliographies here. Some of these are old. Is that our Jewish scholars have been thinking about this for a long time. And although the technology is different from 100 years ago, not to mention from 2000 years ago, the human issues are the same. And you can always go back to some of these texts. Jacobovitz, that was the first modern text of halachic perspective on medical ethics. Steinberg is a great book too, that's much more recent. And what's interesting is how you contextualize the problem. It's very, I don't want to say easy, but it's natural that that medical professionals and nurses and so on will go down the path of jargon and particularism related to the nature of the case today. And I always say, pull back a second and try to see what are the big issues here. And the big issues relate to human issues that are millennia old already.
I mean, what were you? What can I ask you? What were you planning for at the let's say around November of 2020, when at the darkest part of the pandemic? I mean, you were looking at a cliff at that point in time. If you remember, that was the worst.
I remember. I think January was the worst actually, because I went on service in January, and so I just couldn't believe it. You know, I thought we had gotten past the waves, but there we were. So
what were you? I mean, you had to be looking at, you know, distributing equipment and resources and people. What were the discussions that you were having about who are we going to let live and who are we going to?
Well, it was, we did the same thing on vaccine priorities. Or did you not know that?
I did not know that.
Yes, we made
Did you know that?
our own recommendations internally. The governor chose to do completely something different, but we prioritized who should have first access to vaccines. So we did this justice business, distributive justice, at all stages of the pandemic. And fortunately, in California, we were never in the position that they were in New York. So we didn't have to initiate any of these things, but we drew up the plans. And of course, it was a little better than a Kahain before a Levite before an Israelite, a man over a woman. But it was as flawed as that.
Oh, man.
It was every bit as flawed as that, but it was contained in jargon. A young person over an old person, a person without comorbid medical condition versus somebody with comorbid medical condition, a person who developed COVID out of the blue versus a person who had had a transplant. Well, that caused a firestorm because transplant, the organs are very limited. And if somebody had been well, but for the sake of the transplant, you're going to let the person die, you've actually contributed to do two deaths because the person you harvested the organ from was going to die anyway. But now the organ is going to die with the patient. So we went on those things for hours and hours.
Gary, what body or group or committee made those decisions?
Well, that was the other part of the flaw. We have an ethics committee, and they convene the chiefs of all the services. So I'm the chief of bone marrow transplant, and then there was the clinical chief of oncology. You know, you can imagine our patients were pretty low down on the list for trying to save. You know, they really pushed our patients way down the list. Every service. So these, there were 50 people on the Zoom conference call. And then ultimately the regents of the board of, I told you this, the regents of the University of California said, we're not going to allow this because we can't have a different set of criteria at different hospitals within the UC system. We need one system. And so we'll create it. Thank you very much. Goodbye. On the vaccines, there was a lot of politics in the vaccines. I do want to remind you, although it's politically maybe not wise to say, but I think that under Trump already, hundreds of millions of dollars were spent on vaccines where there were no data yet as to efficacy. So we knew that they were going to come, and we were pretty hopeful that they were going to work. So what we did was we prioritized healthcare workers, as you know, and even among healthcare workers, there was a priority on the basis of zip code where you lived. So if you were in an area that was underserved medically and in which there was high incidence and you were a healthcare worker, you got the first tier. Now, age came in as the second tier. The third one that I pushed hard on was service. So I said, well, I'm coming on service on January 15th, and we've got a surge, and I need to have gotten both of my vaccines by January 15th. Well, that didn't get me in the first tier, but it got me in the second tier, fortunately. And then, as you know, the governor kind of blew all of that apart when he said, well, I don't want any of those things. I just want people over the age of 65 after healthcare workers. So you can have all the healthcare workers, and then the next tier is just going to be on the basis of age, without discussion of zip code or what their value is and whether they have chronic medical conditions or not, or if they're on immunosuppressive drugs or not, things like that.
How was it that people in the entertainment industry were prioritized over people with existing health conditions?
Well, I heard those things too, and they weren't supposed to be, but as you know, the process is a little porous. The ship is a little leaky, and so it takes on water. I heard of people who knew people who somehow had access. I'll tell you, I had no extra access, and the chief medical officer of the hospital had no special access. Neither of us were in first tier.
Well, we know someone who happens to be a Wilshire Boulevard member. She works in entertainment, and she received an email from UCLA saying that she should come in and get the vaccine. She had no other prioritization.
Well, yeah, that I can't explain to you, because we had a system where you got a certain number of points based on your immunocompromised status and your age. And we never really could actualize that system because, as I say, the governor really wanted everybody over 65. So the idea was that if you were not over 65, but you had had a lung transplant, you would get several points, or a bone marrow transplant, you would get several points. And the greater the number of points, the earlier you get your invitation. But I can't, how could I comment on a specific case? It's a justice issue, and distributive justice is always difficult. And you see how in halakha, if you're not a Levite and a Kohen, but you're a scholar, that might move you to the front of the line too. So these are always problematic. They're always arbitrary. There are entire societies, that have reconstituted themselves based on distribution of limited resources. I always like to say that resources are not as limited as people like to say they are. That the money you save on taking care of an elderly person on a ventilator will never go directly to vaccinating poor children. It'll go through some other person's hands and be stuck in some administration portfolio before it'd ever get to kids. So it's a false kind of division or dichotomy.
But that's not to say that we should engage in futile care.
Correct. But who determines futility? Famous article in the journal Science. Who rather than what? But you could ask also what determines futility. And that's another long discussion. Well, I thank you all for the opportunity to engage with you. You really also made me think a lot and made me revise my slides and do some more reading. And this is something that we can continue to study. And hopefully my prayer is that nobody should have to go through any of this personally, but all of us do in some way or another, I know. And so I thank you all and wish you a good night and a good luck in continued Jewish study.
Thank you so much for doing this.
Thank you so much.
Thank you.
Thank you.
Thank you.